So thank you very much for the opportunity to present to you some exciting updates in the management of pancreatic cancer, a cancer that I truly believe in the next 5 to 10 years will have a very different therapeutic landscape. And so I'm going to cover three main topics: the optimal management of early stage disease with a number of publications in 2025, biological insights and what we want to know from our molecular profiling in 2026, but thinking about future biomarkers and how they might inform the use of KRAS inhibitors in our clinics, and particularly thinking about combination strategies in the future and also in the design of our combination clinical trials. So firstly, thinking about early stage disease, I want to draw your attention initially to the bottom left-hand side of the screen, where you can see from Cancer Statistics 2026 that we have made some progress in terms of overall survival at 5 years for patients with pancreatic cancer, perhaps owing to earlier detection of pancreatic cancer, but better use of our systemic options also. And so now to think of how we might manage a patient with upfront resectable pancreatic cancer today in our clinics. And a number of guidelines will tell us that the optimal management is surgery followed by adjuvant chemotherapy, preferably with modified FOLFIRINOX. However, I also think it's important to note definitions of resectability. And to date, many of our clinical trials have really focused on anatomical definitions, usually referring to the NCCN guidelines. But more and more, we have seen data to incorporate biology with CA19-9, for example, greater than 500, but also patient factors, so ECOG performance status, but perhaps also systemic symptoms. So if a patient has weight loss or back pain, this might suggest more systemic disease, more advanced disease, necessitating an induction chemotherapy approach. But what is the optimal approach for either resectable or borderline resectable pancreatic cancer? And there have obviously been a number of studies, and I'm really highlighting here a select few, and in particular 4 trials that were published in 2025, looking at different chemotherapy regimens in the neoadjuvant setting, and CISPD1, for example, looking at the sequential approach of gemcitabine and nab-paclitaxel and modified FOLFIRINOX. But I'm going to focus on PREOPANC2 and Cassandra. So PREOPANC2 really sought to evaluate FOLFIRINOX full dose or gemcitabine and radiation therapy followed by surgery, and in the case of the gemcitabine arm, more gemcitabine thereafter. Patients included had resectable or borderline resectable pancreatic cancer according to the Dutch Pancreatic Cancer Group's definitions. 65% of patients included had resectable disease, and of note, the majority, so 70% of patients, had a CA19-9 less than 500. And of course, if you look towards the right of your screen, you can see that there was no difference in median overall survival between the two regimens, so 21.9 months versus 21.3 months, suggesting that both of these regimens can be considered for patients with either resectable or borderline resectable pancreatic cancer. This trial was particularly important as it did inform the Cassandra trial. So the Cassandra trial initially established itself as a phase 2 randomized clinical trial, but based on PREOPANC2 actually became a phase 3 trial. So the different chemotherapy regimens were PAX-G, so this was a quadruplet chemotherapy regimen of cisplatin, nab-paclitaxel, capecitabine or gemcitabine, or modified FOLFIRINOX. And this trial underwent a 2-by-2 factorial design. So patients underwent an initial randomization to different chemotherapy regimens, but after 4 months underwent a second randomization to really determine the optimal timing of chemotherapy in the neoadjuvant setting. So some patients continued to 6 months of treatment followed by surgery, and others underwent surgery followed by more chemotherapy. Now, of note in this trial, borderline resectability did include patients with anatomical resectable disease, but CA19-9 greater than 500. The primary endpoint of it was event-free survival, as defined by RECIST 1.1 in terms of progressive disease, recurrence, unresectability, intraoperative metastases, and death. But of note, also included CA19-9 failure, a perhaps novel way to define progressive disease in pancreatic cancer, and was defined by 2 consecutive increases by 20% separated by 4 weeks. And when we look at the primary endpoint of this trial in terms of event-free survival, we can see that this favored the PAX-G arm at 16 months versus 10.2 months in the modified FOLFIRINOX group. And notable to oncologists really for the quadruplet regimen were that we saw similar rates of grade 3 adverse events. Now, there are a number of things to note about this trial. This was an open label study, and I think if we look at the modified FOLFIRINOX arm, this may have underperformed if we look at other clinical trials of resectable pancreatic cancer. The primary endpoint of event-free survival did incorporate CA19-9 failure, and of course this is not validated as a endpoint in pancreatic cancer, but certainly is a novel way to consider this disease. And so a positive study, but it's to be seen as to whether many will use PAXG in their clinics, given that this was a combination therapy used in Italy in this trial. I think a number of questions in early stage disease still remain, but are soon to be answered. So for example, should resectable pancreatic cancers all undergo a neoadjuvant systemic therapy approach? And I think Alliance and PREOPANC3 will answer this question for us, really recognizing that half of patients do not receive adjuvant chemotherapy in the real world setting. This, of course, considers modified FOLFIRINOX in the preoperative and the postoperative setting. And the optimal neoadjuvant regimen is really uncertain. But I think Cassandra and PREOPANC2 have proposed a number of different regimens that can be used, whether it's modified FOLFIRINOX, gemcitabine-based, or potentially PAXG. And the overall survival data, I think, in this trial will be important. So I just want to mention patients who undergo upfront resection and what the options will be. And I think there is really exciting data on personalized RNA-based neoantigen vaccines. And we can see, as presented here, the patients who undergo upfront resection and have autogene cevumeran, followed by modified FOLFIRINOX, and atezolizumab also is given postoperatively. And this was long-term data presented on this last year. And if you look to the right of your screen, you can see really very impressive median recurrence-free survivals and overall survivals that have not been reached in those patients determined to have a response to therapy. And I think if you look at the bottom of your screen, what you can see is the responders are really dependent on response to the vaccine, which really induces these long-term CD8 activated T cells, really suggesting that the responders to this vaccine are unlikely to get recurrence. And of course, we await the results and the ongoing trial ENCODE 003, where patients will be randomized to the vaccine versus standard of care. So next, moving to biological insights and thinking about what we might want to know today in our clinic. So for patients with advanced pancreatic cancer, I think there are a number of aspects to the DNA information that we want to know. So we want to know whether a patient has a KRAS mutation versus a KRAS wild type tumor, because we know there are a number of agnostic targeted approaches that we can pursue in patients with KRAS wild type pancreatic cancer. And of course, we want to know if a patient is mismatch repair deficient or if they have a germline pathogenic variant in BRCA or a somatic variant in BRCA or homologous recombination deficiency, which opens up a number of therapeutic strategies. I do want to highlight MTAP loss as a very promising biomarker in pancreatic cancer, and a number of trials are ongoing. But aside from these four particular aspects in pancreatic cancer, what else might we want to know? Well, I think, of course, we all want to know the different specific mutated alleles in KRAS for pancreatic cancer patients, but also I think the amount of KRAS, so this KRAS dosage that we are now beginning to learn a little bit more about in our clinics, is also going to be important. But also thinking beyond genotypes and looking at RNA-based subtypes in pancreatic cancer, recognizing this dichotomy of classical and basal-like. And although as clinicians, we like to think of it as a dichotomy, this much more likely consists on a continuum, but is going to be important, I believe, for combination strategies and for KRAS inhibitors in our clinics. And so I first want to mention this concept of RAS dosage. So this is often described as having more mutated KRAS compared to the wild type allele. And we can see two publications, so from the COMPASS trial and from the Memorial Sloan Kettering data, really showing us if you have more mutant KRAS, then your survival is going to be a lot less. And if you look at the bottom of the screen, you can see from this table that if you have balances in your mutated KRAS versus your wild type allele, your responses are much higher at about 32% agnostic to the chemotherapy, but you're much less likely to respond to our systemic chemotherapy options of modified FOLFIRINOX and gemcitabine and nab-paclitaxel if you have much more mutated KRAS. What we also know is that the more mutated KRAS you have, or this higher dosage of RAS, or major imbalances in mutant RAS, that you're more likely to have this basal-like subtype. And of course, this associates with metastatic disease and a worse overall survival and an inherent resistance to our chemotherapy options. But we also know that these different subtypes may have different and unique tumor microenvironments, perhaps posing opportunities for us to combine particularly chemotherapy or RAS inhibitors in the clinic. This became apparent from the PASO-1 trial published last year, where we saw in de novo metastatic pancreatic cancer, excluding patients with germline pathogenic variants in BRCA1, 2, or PALB2, that we saw no meaningful differences in modified FOLFIRINOX versus gemcitabine and nab-paclitaxel. But if you look to the right of your screen, we are consistently seeing that patients with basal-like pancreatic cancer who are treated with modified FOLFIRINOX seem to do particularly worse. And I do think chemotherapy regimens and biomarkers associating with these chemotherapy regimens will be important as we begin to think about our combination strategies. And that, of course, brings us to this opening of our dam of RAS inhibitors. It's really a very exciting time, and I think we can think about RAS inhibitors in different ways. So we have mutation-selective inhibitors. We're very familiar with sotorasib and adagrasib for G12C mutations, but of course representing only 1 to 2% of patients with pancreatic cancer. We have pan-KRAS inhibitors and pan-RAS inhibitors like daraxonrasib that we're more familiar with. But if you look to the right of your screen here, you can see really how hugely progressive this field has been in terms of drug development. Of course, we have a number of drugs targeting KRAS G12C, but also increasingly G12D. And I think notable that we're finding it more difficult to target G12R mutations, particularly these are represented about 15 to 20% of patients with pancreatic cancer. And of course, we have our pan-RAS inhibitors, and there are different ways to target RAS, which I think are important. We have small molecules, we have protein degraders, and of course, we have vaccine strategies. But first, thinking about the data that we have seen for daraxonrasib, particularly in second-line pancreatic cancer. And so this slide here really depicts the early phase data, which looked at different dosing levels of daraxonrasib. And here presented is the 300 milligram dosing in second line. And you can see median progression-free survivals of around 8 to 9 months and overall survival of about 13 to 15 months. And of course, this is really unheard of for patients with second-line systemic chemotherapy. Looking to the left of your screen, you will see that really this is in the realms of 3 months with overall survival of 6 months. And we know how difficult it is to treat patients in the second-line setting. If you look towards the middle bottom of your screen, we're seeing how useful ctDNA may be in tracking the RAS-FAFs under the pressure and evolution of these KRAS-targeted drugs, where you can see that clearance of the KRAS mutation may be particularly important in predicting those who are going to respond. And I think we're all eagerly awaiting the publication of the RASolute 302 study, which may really define a new standard second-line option for our patients with pancreatic cancer. And of course, ongoing is the RASolute 303 study, looking at patients in the first-line setting as monotherapy, gemcitabine, nab-paclitaxel, and daraxonrasib with maintenance arm versus gemcitabine and nab-paclitaxel. And already moving quickly into the adjuvant setting, we're seeing daraxonrasib versus observation after completion of systemic chemotherapy. And there are, of course, other KRAS-targeted agents, and I'm presenting here just the ASP3082 that we saw presented initially by Dr. Park in ESMO 2024. So this is a protein degrader, and what we see at the 600 milligram dosing, if you look towards the left bottom of your screen, response rates in really heavily pretreated patients with monotherapy at about 20%. But what we saw at GI ASCO this year was more data on this protein degrader already in combination with chemotherapy, proving safe, but also really showing how much our response rates can increase when these drugs are potentially combined with modified FOLFIRINOX. And again, highlighting the potential for ctDNA as a biomarker, a dynamic biomarker, when these patients are receiving these treatments. We've also seen a number of specific KRAS G12D inhibitors targeting in both the on and off states with HRS4642 in combination with gemcitabine and nab-paclitaxel, high response rates of 63%, perhaps more toxicity than we expected with myelosuppression, perhaps owing to the chemotherapy in this arm. And then on the right-hand side of the screen again at GI ASCO this year, showing INCB 161734. And again, some combination data presented, but really exciting monotherapy data also with response rates at 37%. Again, in this particular trial, I think very interesting that molecular responses were being defined as those in greater than 90% clearance of KRAS-FAFs in the ctDNA. And already, it's really quite amazing to see that we don't have a standard KRAS inhibitor in our clinic, but we're already beginning to think about resistance mechanisms. I'm talking about beyond a G12C inhibitors. And we have learned a lot from our G12C inhibitors in terms of resistance mechanisms. And we can see here from this publication in 2024 that we do see de novo and acquired resistance mechanisms, really thinking about those biological insights that I was talking about in terms of amplification of mutant KRAS being particularly important in the de novo and acquired resistance setting, but also adaptive resistance mechanisms such as amplification of RTKs, including EGFR, MYC, and acquired MAP kinase alterations such as PIK3CA activating mutations. And we saw some early data presented at AACR last year for daraxonrasib acquired resistance mechanisms as well. And I think more to come on this, but this is really going to deliver an approach for us in terms of combination strategies. And of course, I think it is notable that not all mechanisms of resistance are genetic. And again, going back to the biological insights, what we see is this importance of cell states. So remarkably, perhaps some sensitivity early to basal-like pancreatic cancer cells with RAS inhibitors, and perhaps the classical state representing a marker of resistance. And so how this will evolve for us is yet to be determined. And really, finally, looking at targeting RAS with vaccines. And we are aware of the Amplify 201 trial, and we had updated data presented last year. And we can see here median overall survivals of 28.9 months and recurrence-free survivals of 16 months. And this is really in a high-risk group with positive ctDNA post-operatively. And again, what we can see here is those who really get these T-cell responses. This was CD4 and CD8 based T-cells. You're really seeing very durable responses. And of course, the Amplify 7P vaccine trial has just completed. And so this is antigens targeting 7 different forms of mutant KRAS. And I think it'll be exciting to see where this fits in our clinical treatment paradigm. I'm going to stop there. These are my summary slides, and thank you very much for your attention.